Network, and I would like to welcome you to our webinar series. These webinars have proven to be an excellent way for the network to reach individuals across the country. Tonight we'll be discussing hearing preservation, rehabilitation in neurofibromatosis type 2. Hearing preservation or restoration is a major goal in the management of NF type 2. This discussion describes the management of patients with NF2 to prolong or restore useful hearing. Techniques may include decompression of the tumor to preserve hearing, tumor removal with hearing preservation, or restoration of hearing with cochlear implants or auditory brainstem implants. I'd like to give you just a few instructions here for the webinar. The captioning is being provided tonight by Captions Unlimited, and you should be able to see the captioning on your screen. After Dr. Brackmann's talk, we'll have some time for questions and answers. To write a question to be read aloud, you click on the question box on the lower portion of your webinar control panel. And to remove that control panel, which might be necessary for you to view the whole screen, click on that orange rectangular button with the arrow. Tonight we're very fortunate to have Dr. Derald Brackmann, a neurologist with the House Clinic in Los Angeles, who is an international NF2 expert. I've heard patients of Dr. Brackmann say that he's knowledgeable, kind, he's listened to me, has great bedside manner, and I've even heard he saved my life. Many of you are already familiar with the House Clinic in Los Angeles and are well aware of the expertise he brings to us tonight. So without any more delay from me, I would like to introduce all of you to Dr. Derald Brackmann. Welcome, Dr. Brackmann.
Well, thank you very much, Cam, and thank everyone for inviting me. It's a great pleasure to be able to speak with you this evening. This first slide, the disclosures, you know, we have to now declare if we have any financial interest in anything, and I don't. So we'll get right on with the lecture. The treatment options, Kim has already mentioned a couple of these, but I'll go through each of these this evening. And sometimes the best treatment is nothing. And I'll go over with you sometimes when we observe tumors. She has already mentioned decompression, removing the bone from around the tumor to take the pressure off to prolong hearing. And then we go to surgery, hearing preservation surgery, sometimes with partial tumor removal, preferably with total tumor removal. And then something relatively new in the field is use of cochlear implants in NF2. And then finally, I'll talk about hearing preservation, non-hearing preservation surgery, and the auditory brainstem implant. I'm not going to talk much about stereotactic radiosurgery. That's another whole subject unto itself. I will say that, unfortunately, it is oftentimes not a hearing preservation technique. With time, many patients do lose hearing with stereotactic radiosurgery, but I will mention the possibility of a cochlear implant in such patients where we've had some success. Finally, you're all aware of the possibility of drug therapy prolonging useful hearing, and that's another subject which could be another whole webinar unto itself, which I will not discuss. So let's go on to observation. Sometimes the best thing to do is nothing, and the patients that we would observe are, first of all, small tumors. You know, if you have a very large tumor, that's not one to observe, but small tumors, particularly those that are unfavorable for hearing preservation. The tumors that are favorable for hearing preservation are the small tumors that are not impacted into the end of the internal auditory canal, that have good hearing, and obviously not one that has brainstem compression, which is endangering the patient's life. But if you have a small tumor, particularly when first diagnosed, you really don't know the behavior of it, and there's a great variability in the behavior of tumors. Some tumors will grow very slowly and some not at all. So it is not a bad idea to observe a tumor when it's first diagnosed to see what the behavior of it will be. Now, if the tumor is growing and you begin to have hearing deterioration, one can consider decompression. Now, what decompression is to remove the bone from around the internal auditory canal, the inner ear canal. Now, these are benign tumors. The way that they produce the hearing loss is by pressure on the cochlear hearing nerve. So if you can remove that pressure from the hearing nerve, you may be able to prolong useful hearing. So the indication for doing this are medium-sized tumors with hearing deterioration. If the hearing is stable, we would not offer this, but if the hearing is deteriorating, it's something to consider. Now, our group published a review of the indications and the results of hearing preservation a little while back, and this is a review of that paper. You'll notice that this was over a long period of time, nearly 20 years, 19 years, where we performed 49 patients. 45 of them were in patients with NF2. 4 were patients that had unilateral tumors with hearing loss in the other ear. If they are having a greater than 10 decibel loss of hearing or greater than 12% loss of speech discrimination, we define that as hearing deterioration and offer these patients a decompression of the internal auditory canal. These would all be patients that we did not feel were suitable candidates for hearing preservation with tumor removal. This graph shows the percent of hearing preservation on the x-axis and or the y-axis and the time after surgery. The conclusion, rather than looking at the graph, the conclusion of that is that the hearing was maintained at the same level, an average of 2.1 years. So you might say, that's not, is it worth a major operation to preserve the hearing for 2.1 years? Well, perhaps you could question that. But if you look toward the right side of the graph, there were patients who had their hearing maintained 9, 8, 9, 10 years, and for them it was certainly worthwhile doing. Whenever you're considering a treatment, you have to consider do no harm. So we carefully looked at whether any patients lost hearing as a result of the surgery, and you'll see there on the left side, that's the pure tone average, meaning the tone average, and 1 month before and 3 months after surgery, they're essentially the same. So no patient lost hearing as a result of the surgery. The SCS, that's speech discrimination, the word test, and there too, there was no change 1 month before or 3 months after surgery. So it is a safe procedure, but it is a major operation and one that you have to take into account when you're considering it. The hearing preservation class, here again, 2/3 of the patients at 1 year after middle fossa decompression had serviceable hearing, and 50% of them at 3 years. So again, it's not the answer for the long term for patients, but it may prolong useful hearing for quite a while, and we have had no complications related to the surgery. No one has lost hearing as a result of the surgery. So we do offer it to patients with medium-sized tumors, not good candidates for hearing preservation and total removal, and those that are having progression of their hearing loss. So let's go on now with this conclusion. So it's reasonable, and again, I emphasize that the mean for hearing preservation is 2 years, but there are some patients have had hearing preserved with slow tumor growth for more than 10 years. Now, how about, now we're getting to surgery to remove the tumor. We rarely do partial removal. Now, that has been done, and sometimes successfully, but oftentimes the hearing is lost and there's rapid regrowth of tumor, so we rarely do partial tumor removal. Now, the reason that we think that the hearing is often lost is this slide. At the top, the dark fibers going through the light pink are the nerve fibers. The light fibers are the tumor. And you see in the sporadic, meaning the non-NF2 tumors, unilateral tumors, tumors on one side, the nerve fibers are on the surface of the tumor, whereas at NF2, the nerve fibers go directly through the tumor. So that for that reason, we think that hearing preservation is rare and the hearing is often lost, even with partial tumor removal, which is why we rarely do it. There are occasions where it can be done. I'm sure everyone knows of such a case. I certainly do. But in general, we do not recommend that. So we like to, if at all possible, do a total tumor removal. Now, this is a little controversial. There are some who say that that shouldn't be done, that these small tumors should be observed, but I think I can show that it's useful to preserve hearing long term and something that should be considered. We call it early proactive management, meaning early when the tumors are small, and proactive rather than reactive management of NF2. This is the title of a paper that was about 20 years ago now, when we reviewed 28 patients with had 40 surgeries. You see the demographics there. There were more males than females for some reason. 11 patients had bilateral procedures. Now, why would you do that? Well, if we did the first side and hearing was preserved, we then did the second side. On the other hand, if the patient lost hearing with the first tumor side, then we would observe them. We have on about 3 occasions now, removed the tumor from the only hearing ear in all the members of one family who insisted on it, and fortunately, and I'm knocking on wood, fortunately they all had their hearing preserved. But generally, if we lose the hearing with the first tumor removal, we observe the second tumor, perhaps do a decompression, but do not do the second tumor side, except in rare circumstances where it's very favorable and with the patient's insistence. This one patient had the surgery on the same side, her tumor recurred, and we did another surgery, and unfortunately she lost her hearing with the second surgery. Most of these patients you see are young, although we had one elderly patient, older patient, who was in very good, he was a young 70, and we offered the surgery to him and he accepted and did fine. So this is a little complicated, I'll have to explain this slide to you, but the pre-op is in the blue to the left of the slide. Let me explain what classes of hearing are. These are from the Academy of Otolaryngology, Head and Neck Surgery has defined these. Class A hearing, let's just define it as normal. Class B hearing would be some hearing loss, but the ability to hear without the use of a hearing aid. Class C would be patients who have significant hearing loss, but another 3 patients had Class C hearing. It's interesting on the Class C hearing, then in the center is the post-operative hearing preservation. And so of the 34 patients who had Class A hearing preoperatively, 20 of them, or 58.8%, had Class A hearing postoperatively. Another 3 had Class B hearing, so 2/3 of them had normal or near normal hearing, and the other 32% lost all their hearing. For Class B hearing going in, there were 3 of those patients postoperatively. 1 maintained normal or the same hearing. 1 had deterioration but could still use a hearing aid, and the other lost hearing. It's interesting that even the one with Class C hearing maintained it. So the better the hearing, the more likely you are to have hearing preservation. That's just logical that the less the hearing nerve is involved, the more likely you are to be able to preserve it. But even with some hearing loss, some of these patients maintain normal hearing. So there at the bottom is sort of the summary of that, rounded off, that overall 50% of the patients maintained perfect hearing, 10% had very good hearing, 5% had hearing that you could still wear a hearing aid, and 1/3 or 35% lost their hearing so that they could not wear a hearing aid. So not perfect results, but still if you do nothing over time, although it may be a long time, but over time patients are likely or almost certainly going to lose their hearing. So this possibility to maintain hearing, and sometimes for a lifetime, is certainly attractive. Now, a facial nerve, we sometimes get so hung up on the hearing that we tend to ignore the facial nerve. And I've had many of my young patients say, I wish that I had thought more about my facial nerve and been less concerned about my hearing. So that the facial nerve is extremely important to preserve in patients, and all patients, but particularly in the young patients often affected by NF2. So preoperatively, the majority of them had normal facial function. A couple of them had some facial nerve weakness. Facial nerve grades, I think most of you are familiar with that. This is a grading system that Dr. House and I developed, and grade 1 is normal. Grade 2 is just a mild weakness, only your family knows. Grade 3 is a significant weakness, but you can raise your forehead. Forehead motion can persist. Grade 4 is you look normal at rest, but there's significant noticeable weakness with smiling, and you cannot move the forehead. And then grade 5 is only a slight bit of motion. Grade 6 is no motion. So preoperatively, most of these patients had normal or near normal facial nerve function, and postoperatively they were about the same. So all of them had either grade 1 to 3 facial nerve outcomes. So the facial nerve fared very well in these patients with the tumor removal. Our conclusion from this study was that you should screen asymptomatic offspring. As all of you know, NF2 is a genetic inherited disease. When one parent has the disease, the offspring have a 50-50 chance of being affected. So we recommend screening for all children of patients with NF2, even if they have no symptoms. If you wait until they have hearing loss or other symptoms, oftentimes the tumors are very large before they produce symptoms. That's one of the cruelties of NF2, is that hearing can be preserved or not be affected until the tumors are very large. So we recommend screening of all children who have, even if they do not have symptoms. There's another whole lecture on genetic testing. Genetic testing, if you know what the mutation in the gene is, can be very effective for screening offspring. So I would urge any of you who are going to have surgery to request your surgeon to submit the tissue for genetic testing, because the geneticists tell me that it's relatively easy to identify the gene from tissue, but it's very hard to identify it in blood. But if you know where to look and know the mutation, then you can test the blood of the offspring and see if they have the mutation, which would save them doing repeated MRIs and so on. So I would urge all of you to consider genetic testing if you are going to have surgery. Have the tissue tested to identify the mutation. So if we find a small tumor in an asymptomatic patient, we feel that if it's favorably placed, you have this 2/3 or greater chance of preserving hearing, that you should offer the patient middle fossa removal on diagnosis. The youngest children we've operated are 6. They do very well, and they sail through the procedure. It's a difficult decision for parents to make, but I think that that should be considered for favorable tumors. Now, we've done a subsequent examination and study and paper on hearing preservation, a subsequent different paper, a different group of patients. Dr. Goddard was the fellow at the time, and you see the names of my other associates. So this paper was from about a 10-year period, from January of 2000 to June of 2010, so more recent than that last paper. They were all NF2 patients. All of them had hearing in the other ear. In other words, there were none of these patients that were operated with their only hearing ear. We didn't include any people that were non-NF2, none that had prior treatment, radiosurgery or other treatment, and none that had internal auditory canal decompression. So those were excluded from the study. So here's this, there were 55 cases, again, 37 patients, because that would be 18 of them had bilateral surgery. Again, these were young patients. The average age was 21.6. The youngest was 12.4. Average tumor size was 1 centimeter. These were small tumors. The smallest tumor was 4 millimeters. All of them had good hearing. Remember, anything up to 25 decibels is considered within the range of normal. The average was 16.8 decibels, and the word discrimination, 95 or a little bit better than that speech understanding. So all of these patients were young, had small tumors, and had good hearing. Here's the hearing outcomes. They're not all that much different than the first study. Again, about 2/3 of them had useful hearing. And the most important part for hearing is the word discrimination. You know, you can stand to have a little bit of loss for the tones, but if you can understand well, you can use a hearing aid to great advantage. So the average word recognition score for these patients was about 94%. And these were followed an average of 3 years, some of them much longer. The 87 months is what, about 8 years, no, 7 years, did develop, did have late onset of hearing loss. The reason for that is persistence or recurrence of tumor, which I'll mention next. Facial nerve results, first of all, are just like the other. There were very good facial nerve results. Over 90% had grade 1 or 2, meaning normal or near normal, and there was only one patient who had a grade 5, not a total paralysis, but a severe paresis. So here was something, though, that was disturbing, disconcerting. We had 47 patients, 87%, where we were able to follow with MRI, and that was an average time of about 5 years, and 59% of them had recurrence of tumor. Now, they were small, averaging 1.39 centimeters, but the tumors occurred, as you see at the bottom of the slide there. 21% of them were on the facial nerve, others were on the cochlear nerve. So that is a problem with hearing preservation surgery, that you're liable to leave a few cells of tumor either on the facial or the cochlear nerve, which then have the possibility of regrowth. Now, despite that, though, you'll notice in the last line there that despite the fact that there were some regrowth, that the majority of them maintained normal hearing. So even though there was some tumor regrowth, the tumors were small, they were continued to be observed, but they maintained good hearing, and this was for a period of more than 5 years, some of them up to 10, 15, 20 years. And there are some of these now, you know, if you look at the other side of this, that means 40% of patients did not have tumor regrowth and may go a lifetime with hearing preservation without tumor. So to summarize the second study, 50% maintained normal hearing, 63% maintained serviceable hearing, in other words, hearing that was aidable with a hearing aid, and 94% had grade 1 or 2 normal or near normal facial nerve function. And then the downside, 60% of them had tumor present at 5 years post-operatively, and that's something that we didn't really study long-term in that first paper, and this was somewhat disconcerting that it doesn't subtract from the conclusion that the middle fossa approach for small favorable tumors is something that should be offered to patients, and it can cure some patients, but it may only prolong useful hearing in others. One thing that I'll talk about in a little bit is that if you can preserve the cochlear nerve, even if you lose the hearing, those patients can be rehabilitated with a cochlear implant, which is greatly useful, and I'll mention that toward the end. But the other point of this, because there is the possibility of the tumor recurrence, it's very important that routine MRI scans be done periodically. You know, we do one at 6 months and then at a year, and then at 2 years, and then as the time passes, we can prolong the interval between doing MRIs, but patients with NF2 need to be screened for a lifetime. Okay, let's go on now to the subject of cochlear implantation. This is something that's relatively new. You know, it's always been thought, well, how in the world could a cochlear implant work in someone when they have a tumor on the cochlear nerve? Now, well, first of all, sometimes the cochlear nerve is not involved because the tumor, as you know, these are vestibular schwannomas. They actually begin on the vestibular nerve, and so there are cases where we have done a middle fossa approach. You lose the hearing, but that is due to the loss of the blood supply. You know, the blood supply to the inner ear is derived from the brain circulation. So you can save the hearing nerve, but still lose the hearing because you've interfered with the blood supply to the inner ear. And so the hearing nerve will still function to make it amenable to a cochlear implantation. So that's one case, but as you'll see in a minute, and I'll go on to that actually, there are patients that have tumor in place that will benefit from a cochlear implant. Now that's a relatively new concept that was really not realized until a few years ago. So these are the cases where we have done cochlear implants. First is the one that I had mentioned where the tumor is resected, the nerve is preserved, but the hearing is lost due to loss of blood supply to the cochlea. So those patients may benefit from a cochlear implant. And we have several patients now, in fact, quite a number of patients who have lost their hearing following radiosurgery, which has stabilized their tumor, but they can benefit from a cochlear implant. And that's something that is counterintuitive. You would think, well, how can that be? But it goes back, remember the slide I showed a long time ago where the cochlear nerve fibers grow right through the tumor? So even though they're involved with tumor, they may persist in the center of tumor. And it appears that the reason that the hearing is lost with stereotactic radiosurgery is the effect that it has on the cochlea. The nerve endings or hair cells are very sensitive to radiation, and it appears that the reason that people lose hearing with stereotactic radiosurgery is that the hair cells are degenerated and the hearing nerve remains to be able to be stimulated. So I'll show some cases of that where a large tumor actually that's been stable, the radiation has stabilized the tumor, and the patient has done very well with the cochlear implant. There's also some cases that I'll show in a minute where there is a tumor within the cochlea or a tumor that just hasn't grown, but yet the hearing has deteriorated. And in fact, let me go on to a couple of those now to give you a few case reports about patients that have had cochlear implants with NF2. So this is the first case where the patient had a middle fossa removal on the left side. He lost his hearing, then had a right middle fossa decompression which slowed his hearing. His hearing slowly deteriorated, and we did a promontory stimulation. Now, what a promontory stimulation is it's an office test. You have a very tiny needle that's placed through the eardrum onto the cochlea, onto the inner ear, and then that's electrically stimulated, and you ask the patient, they're awake and able to respond, you ask the patient if they hear a sound as a result of the electrical stimulation. And if they do, you know that the hearing nerve is functioning. And so he was able to perceive a sound with the promontory stimulation test. We then did a cochlear implant in the ear where he had had a middle fossa removal and lost his hearing. And these are very good results. He got 90% of sentences and 80% of words. So to translate that into something that's more understandable, he would have been able to speak on the telephone with hearing like that with the cochlear implant. So he's done very well with the cochlear implant. No tumor has recurred. He must have lost his hearing because of loss of the blood supply to the inner ear. The cochlear implant works very well for him. This is a patient who lost her hearing following gamma knife radiosurgery. This was a long time ago now. It was a large tumor. She lost her hearing. We did promontory stimulation, and which was positive, and she had a left cochlear implant on the ear with the post-radiation hearing loss, and this is another sentence test where she had 81% correct. So she can converse with you with the combination of lip reading as if she does not have hearing loss. Now, she had a very large tumor on the right side, and we removed it totally and did an ABI. And as is common, she didn't do as well with the ABI as she did with the cochlear implant. And that's pretty universal, and we'll talk about that in a minute when we talk about the ABI. Another case, this is a stable tumor. Here you see this is a patient, the large mass, the large white mass on the way an MRI is taken is if the patient is facing us. So the large white mass would be on the patient that's on the left of the screen, would be the right side where she has a large tumor. Now, I don't know if you can see it, but on the right side, it looks like a little worm. In the middle of that black spot, right on the same level as the large tumor on the right side, that's a nerve, that's a tumor that fills the cochlea. You know, the cochlea is like a snail, and this tumor fills her cochlea, and she's totally deaf in that ear, but it is all due to the tumor destroying the little nerve endings, the hair cells, so that the hearing nerve is intact. And so we place the cochlear implant through that tumor, and she does very well with it. Again, all of the types of sentences and so on that are given is on the left there. Suffice it to say that she has a very good performance, that she's actually able to use the telephone on the left side. She still has a little hearing on the right. We are continuing to observe that tumor, but she hopefully will not need to have that removed. But the tumor on the left has remained small, and she is a very good cochlear implant user. So this is several years ago. We have several more of all of these now, but this was the experience at that time. We had two patients who had lost their hearing with middle fossa surgery and did well with the cochlear implant. 6 patients, and there are several more now who have lost their hearing following radiosurgery. And we have several more patients now also where we're just observing their tumor. They're stable, and they have a typical cochlear implant performance. By that I mean that they were able to understand many words without lip reading. Many of them are able to use the telephone, and with combination with lip reading, they're able to function as nearly like a normal hearing person. So when you can do a cochlear implant in NF2, when all of the conditions are right, that's the best way to rehabilitate patients, and something that's often not thought about, but something that you ought to think about and mention to your doctor as a possibility for you. So Matt Carlson at the Mayo Clinic did what's called a meta-analysis. A meta-analysis means you pull all of the literature and you condense it and report the combined experience of a lot of people. And so there were 43 cases at the time when he did the literature review, 31 microsurgery cases that had lost their hearing, 10 stereotactic radiosurgery cases, 2 observation cases, and the great majority of them had open set speech capacity. What that means is that without lip reading, without the patient's, a closed set is where their patient is given, say, 4 words and they have to choose which one. Open set is all of the words. They're able, 70% of the patients are able to get some open set speech capacity. 48% are users of the telephone, 87% are daily users. So again, think about the cochlear implant. That's something relatively new on the scene, which can be very beneficial when the conditions are right. So this is a conclusion of that. I've already said most of this, and you can read that. It's when you can use a CI, it's certainly preferable to an ABI. The majority, 70%, have open set words. There's a little controversy about that third point about preserving the cochlear nerve, because studies have shown that the cochlear nerve oftentimes will have a little tumor in it, so that preserving the cochlear nerve does open you to the possibility of having tumor recurrence. On the other hand, it does open the possibility of a cochlear implantation. Another thing, there's a lot of controversy on the fourth point there about how long the patient is deaf, whether they are candidates for a cochlear implant. But this did not make a difference in these patients. If they had been deaf for a long time and if they were older, it did not affect their cochlear implant performance. So you always have to look carefully at the cochlea in these patients, because when you lose the hearing, sometimes the cochlea will fill with bone, so you can't always do a cochlear implant. And we believe that a cochlear stimulation is also a good test, because some have said, well, it's not worth doing, you just put it in, but you know, cochlear implants are a little over $30,000. So that's, if you can predict who's going to benefit, I think it should be done rather than just putting in a cochlear implant. Finally, we'll talk about the auditory brainstem implant. This can be placed either through the translabyrinthine or retrosigmoid approach. In the United States, it's done mostly through the translabyrinthine approach. In Europe, it's done more with the retrosigmoid approach. These are cases, usually very large tumors, where there is no possibility of saving the cochlear nerve. And that's unfortunately often the case in NF2. I mentioned previously one of the cruelties of NF2 is that it will preserve hearing until the tumors are huge. And I know some of you, and this is something we anguish over, you anguish over, and we do in advising patients, you know, is, well, when do you finally succumb to the desire to preserve hearing while you watch the tumor grow? And it's a very difficult decision that only the patient can make. Avastin has changed that a little bit. You know, now the hearing may be restored or improved for a time with the slowing of growth of the tumor with Avastin, but still eventually, in the majority of cases, unless you're proactive and can remove the tumors when they're small, eventually the tumors often will need to be removed. And so the auditory brainstem implant, as you know, Bill House and Bill Hitzelberger did the first one of these in 1979. And this has been published, so her name is not a secret. Marilyn Davidson is her name. She is now well into her 80s and still uses her, she had a single channel adaptation of a cochlear implant that Bill House and Bill Hitzelberger placed onto the cochlear nucleus in the brainstem after a tumor removal. And she still uses it. She benefits from it. She was a true pioneer in the development of the auditory brainstem implant. This is a picture of the current devices made by Cochlear Corporation in Australia. There's another device developed in Austria, the Med-L device, and it's equal in performance. It's not licensed in the United States, so the implant that we have used exclusively is the nucleus. This is the latest iteration. Actually, there's a new one coming out the first of the year, which is going to be the same, except it's going to have a configuration that's a little different, a little bit thinner, and so on. But this is basically the cochlear implant, but rather you see the to the right there, you have the antenna. You notice it has a removable magnet. You know, as you know, MRIs are difficult to do in the case where there's a magnet in the field. This can be removed, and that's what we routinely do. We remove that magnet and replace it with a metal disc so that you can then have MRIs without any concern. Just to your left of the antenna is the receiver stimulator. This is where the auditory processing takes place. And then you have a ground electrode on the top and then the active electrode. And rather than a cochlear implant which has 24 leads or contacts along a long electrode, this has 21 platinum discs that fit onto the brainstem. So the device is the same, except the electrode, rather than curling into the cochlea, now fits onto the brainstem with this Dacron mesh and the platinum discs. This, as Marilyn Davidson was the first in 1979, we're now up to about 310 auditory brainstem implants at the House Clinic. We started out with single channel implants, and then there were implants made at the institute itself that had first 2 channels and then 6 channels, and then finally Cochlear Corporation developed the current implant. We did a trial with a penetrating electrode where electrodes went into the cochlear nucleus. These did not prove to be any greater benefit than the surface electrode. And just at the bottom there, we are currently now, this device can also be used in children or other adults where the cochlear implant cannot be used, either absence of the cochlear nerve or ossification of the cochlea. And we do have an FDA study undergoing now where children are being implanted with an auditory brainstem implant, and that's going very well, and the children are receiving benefit from the ABI. Now, I mentioned previously that these patients don't do as well as the cochlear implant, and that's true. So whenever the cochlear implant can be done, it's best to do that. But this shows the blue is the performance on the left, is the performance of percents correct, and this is a sentence test where patients are given sentences and they have to identify the sentence. And the percent correct is on the left, and this varies a great deal. Some patients who have very little benefit, all the way to some who get almost 100% of those sentences correct. But almost always, the blue is what the performance is with lip reading only, and then when you add the ABI to lip reading is the combined total, and virtually all, there are a couple of exceptions. I think 2 patients who did not have enhancement of their lip reading by the use of the ABI. So it's hard to imagine. Some of you, unfortunately, are experiencing it, but for hearing people, it's hard to imagine, what not hearing is like. But hearing anything, many patients have told me, that hearing anything is a big advantage over not hearing anything. And it's something that we that have good hearing don't appreciate, how hearing something can be very beneficial. And these patients do have an improvement of their lip reading. They can hear sounds in the environment. And so even though it is not as good as the cochlear implant, it's sure better than having no hearing. This is a test that shows, this is used to illustrate how a performance is an average of 61 patients, how they did over time. So this is a learning process, just like a cochlear implant. The patients describe the sound they receive as sort of distorted, like a radio, a little bit off of channel. But with time, they do tend to have improving performance. Over even up 7-8 years later, their performance continues to improve as they begin to learn to use the implant. There's a little controversy about whether you implant the first tumor side. We recommend implanting the first tumor side for several reasons. Number one, it gives the patient some time to use their hearing, to learn the implant while they still have hearing in the other ear. We have a 92% success rate with the ABI, but that means there's an 8% chance that the ABI would not work, and if you do it on the first side, then you have a second opportunity to do it in case it would not work on the first side. We now have about a dozen patients who have ABIs on both sides, and it's a definite advantage to hear from both ears. They one enhances the other without any doubt. We've never identified a complication where the patient has been injured by the ABI. So it's been very it's been very safe as well as effective. As I said, 92% get benefit. All are able to hear sounds in the environment and improve lip reading. We now have about, and it's improving, 25% of patients who are able to understand words without lip reading, without having a closed set of words to choose from. So it's getting better, but it's not as good as a cochlear implant, but it is certainly a big advantage over not hearing anything. So what's the future? Well, there are people who are working on more electrodes. There are people experimenting with putting an electrode into the midbrain, into the inferior colliculus. So far, there have been a few of those done. They have not been very successful, but people are continuing to work on the auditory brainstem implant. So I hope that's, and I'm just got 5 minutes left for questions, Kim. I hope that's all right. But you know, the goal and what I as a physician have to think about is with my patients is you want to, you know, unfortunately we still can't cure NF2. You know, drugs are maybe on the future. A lot of genetic research is being done, but we still haven't found that cure. And until we do, what I as a physician and what I think we all need to do is to think of the patient to maintain the best quality of life for the longest time possible for patients with NF2. And that includes preserving their hearing or rehabilitating their hearing if at all possible. And that's what our aim is, as well as preserving their life and other aspects of quality of life. So, Kim, that's my talk. So I think we got a little bit of time for questions.
Thank you very much, Dr. Brackmann. You really helped clear up a lot of questions. But we do have several questions. I'm going to start. The first one that's come in is from Sandy, and she says, do you recommend decompression surgery for a patient with no hearing loss at all and tumors approximately 1.5 centimeters, or would you continue monitoring of hearing until signs of a decline can be better, more conservative approach?
Yes, I would not recommend proactive surgery for decompression because many patients will have slow tumor growth and no hearing deterioration. So I would recommend continued observation, and then if they begin to develop hearing loss, then would be a time to consider decompression.
All right, thank you. This question's from Lauren. She says, our MRI results always report the size of the tumors with two measures, such as 1.1 by 0.5 centimeters. You mentioned measures of 1 centimeter. How do I best understand tumor size on MRI reports?
The classical, if one measurement is given, it's the greatest transverse measurement, meaning within the internal auditory canal from the lateral part of the internal auditory canal to the medial part. Really, you should do 3 measures of the tumor size from front to back, anterior to posterior, from top to bottoms, cranial to caudal, and then transverse from medial to lateral. But typically, if 2 measures are given, that's the 2 that are usually given are from anterior to posterior and from medial to lateral. If 1 is given, it's usually from medial to lateral, which is usually the maximum tumor dimension. But it's better, actually, the way to really do it, and what we do on our drug trials is to do a volumetric measurement, meaning that you measure the true volume of the tumor, which is a better real measure of the tumor size.
Great, thank you. This question is from Cindy. She says, I have had genetic testing twice, but the NF2 gene was not found. Is genetic testing the only screening for offspring?
You had, if I can ask, so you've had blood testing, you've not had tumor testing, you've had blood testing, which is not very accurate. You know, the one geneticist said to me, it's like looking for a needle in a haystack. You know, it's very difficult to pick out a gene among the billions of genes, whereas in a tumor, it's very easy, they say, relatively easy to identify the gene because all of the cells have the mutation in the tumor, whereas all of the cells don't have it in the blood. So other than genetic testing, which can be done on tumor and then identified in offspring with good accuracy, the only thing you can do is just periodic MRIs.
Thank you. Here's another one from Sandy. She says, what are your thoughts on the use of Avastin for tumor control, especially in regards to children?
Well, I'll first of all qualify this by saying that I'm not an expert on chemotherapy for tumors, but and children have their own constraints, I understand. But I have several patients that are being treated with Avastin with good benefit. You know, there's some complications related to it. The kidney function can deteriorate, but I have patients who have been on Avastin now for several years with benefit from their hearing preservation. So I think for tumors with deteriorating hearing, with a carefully planned and monitored treatment, Avastin can be very beneficial. And I can't really comment on children. I don't have any experience with children.
This one is a little bit longer one. This is from Chris. I'm 44 years old and was diagnosed with NF2 last spring. The tumor in my right ear is approximately 1.5 centimeters. Unfortunately, due to the location of the tumor, the chance of my hearing preservation is less than 5%. My hearing has been deteriorating in that ear. I had no word recognition at one point. Oddly enough, over the course of the last 6 months, my hearing has improved and I am about 65% word recognition. The tumor in my left ear is also 1.5 millimeters, and my word recognition is 100%. It appears the tumor has not compromised my cochlear nerve. However, due to the location of the nerve, my surgeon would need to take the and I'm going to spell it for you, Dr. Brackmann, OCCIPITAL approach. He says, I have about a 50-50 chance of preserving hearing, though that approach. I am struggling to make a decision. What has been your experience in hearing preservation taking that approach? Excellent presentation. Thank you.
Thank you. Did I understand that the tumor on the right side is 1.5 millimeters or 1.5? I know on the left side it was 1.5 centimeters. Did I understand correctly? It's 1.5 millimeters on the right?
It says the tumor in the right ear is 1.5 centimeters, and then the other one is 1.5 millimeters.
Yeah, because 1.5 millimeters is a pinhead, and I don't know that I would recommend treatment for that. That's a tumor, the one that's with the hearing fluctuation. This 1.5 centimeters, that's one that we would seriously consider doing a middle fossa decompression on, because you may stabilize the hearing and prolong useful hearing in that ear for a long time. you know, with a 1.5 centimeter tumor, I take it that it's probably impacted into the end of the canal. The hearing preservation rate for removal would be very small. So, but I think with hearing fluctuation, and now that you have 60% understanding, I would consider a middle fossa decompression. That might prolong useful hearing for a long time.
All right, and then this is from Stephen. My son has NF2 and an ABI. He and his wife now have a 3-month-old son. At what age would you recommend testing for NF2?
And I trust that the mutation has not been identified, correct?
We can give him a chance to type the answer to that here, Dr. Brackmann.
Okay.
And while we're doing that, I think I should go back. Chris just said that millimeter should have been centimeter. So
okay.
5 on both sides.
Yeah, well, it would depend. We use the retrosigmoid approach, and it depends on the location of the tumor. You know, if the tumor is more medially located, a retrosigmoid approach would be indicated. If a tumor is more lateral, we would use a middle fossa approach. But and you know, the other things that I didn't discuss, but there are other ways to predict hearing preservation. If you have a superior, you know, there are 2 vestibular nerves. The tumor may arise from either one of them. If the tumor arises from the superior vestibular nerve, your chances of hearing preservation are a little bit better. And the location of the tumor toward the end of the canal is very important. But with a 1.5 centimeter tumor, depending on favorable conditions, I'd say 50-50 is probably a good estimate of the possibility of preserving hearing.
Great. It looks like Stephen has had a chance to answer. Remember, that's talking about the son that has NF2 and an ABI.
Right.
And the answer is correct.
Yeah, that there is no, they haven't identified the gene. Yeah, well, there's really, you could have blood tested, and you may be fortunate, and I was going to use the word lucky, but I guess it's not luck, but you may be able to identify the gene, but if it's negative, it really doesn't tell you anything. And we usually don't screen kids until they're age 6, simply because of the difficulty in doing MRIs and so on. But at age 6, you know, you look for cataracts, you look for all of the outward signs of NF2. But if they're totally, you know, asymptomatic, we would wait until age 6 and then do an MRI at that time.
Okay, and then we'll take this as our last question. This is from Susan. She says she has a 0.33 centimeter tumor, or 9 millimeters, that has taken word recognition from 96% to 75% over the last 4 years. Is it too late to do anything for my hearing? I have 100% hearing on the other side with no tumor.
So she has a unilateral tumor with, well, if it's a favorable tumor, meaning that it's medially placed, that we call it fundal fluid. You know, if there, you can do a special sequence on MRI, call it a T2 sequence, where you can identify spinal fluid as being very white. And if there's a lot of fluid at the end of the canal, and it's a superior vestibular nerve tumor, which you can estimate by doing AB or VNG or balance tests, and you have good ABR, auditory brainstem responses, despite the fact that the discrimination has deteriorated somewhat. If all of those things are favorable, we have about an 80% chance of preserving hearing. And so if everything is favorable, I wouldn't say it's too late to consider taking the tumor out.
Oh, thank you. And now Laura would like to tell you, excellent presentation. Thank you very much, Dr. Brackmann, and I would like to do the same. Thank you very much. We really appreciate you giving up your time and the information and the answering the questions, very specific personal questions for our family. We really appreciate it.
Can I have the last word, Kim?
You sure can. Let me just tell everybody before you, and then I will be glad to give you the last word. And I don't give it so easy. Yeah.
Go ahead, Art.
In a couple of days, you'll be able to see this webinar on the website. So if they would like to view it again, or if they want to have a link and be able to share it with family members, it'll be up on the website at nfnetwork.org in just a couple of days. And now I very generously grant you the last word.
No, I just wanted to tell everyone how I admire the courage, and I've never met a bunch of nicer, more courageous people than people with NF2s. There's something in the gene that makes you nice too. And seriously, I mean, people are just so courageous, brave, and I really admire you for the courage that you display in dealing with this disease. So thank you very much.
Yeah. Thank you, everybody, for attending. Good night, everyone.
Good night.